I am Gary Horndisk, MD, board certified plastic and reconstructive surgeon, and author of Weight Regulation and Curing Acquired Obesity. This is the fifth and last lecture on weight control and obesity. I'm going to talk today about obesity and its treatment. Obesity results from excess fat. Lean weight does not significantly increase. We know that fat weight equals 0.9 times fat volume. Therefore, the control system that controls fat volume creates obesity. Control systems are composed of three components: reference R, amplification A, and feedback F. The most precise regulated control system is feedback dominant, which requires the mathematical product of A times F to be much greater than 1. This results in the constant regulated output O equals R divided by F. Assume a normal weight man is 154 pounds, 5'7", BMI of 24.1 with 20 pounds of fat. He is physically fit, which determines F, and consumes a medium fat diet, which determines A, with the product AF much greater than 1. What happens when the man decreases feedback but still maintains AF much greater than 1? As feedback decreases, fat increases reciprocally, and he will gain fat weight and total weight. For example, if he loses half his feedback, then fat weight will double to 40 pounds with a total weight of 174. As long as AF is much greater than 1, fat weight is reciprocally related to feedback. Consider the same man who has now lost 90% of his feedback, has 1/10 the original, but eats a high-fat diet, 10 times the original fat diet, which still maintains AF much greater than 1. He will have 10 times more fat than before, 200 pounds of fat with a total weight of 334 pounds. Since AF is much greater than 1, he has regulated obesity, which is extremely frustrating. If he significantly reduces the fat content of his diet, and AF is no longer much greater than 1, then O becomes equal to R times A divided by the quantity 1 plus AF. As AF decreases from much greater than 1, O, the output, becomes more dependent on A. This explains how lowering dietary fat reduces weight and obesity. However, if he resumes the previous high-fat diet, the fat increases AF to much greater than 1, which restores regulated obesity. This phenomenon has been observed and has led to some researchers to believe that there is one system that reduces weight and another system that maintains weight. This is incorrect. There's only one control system that does both. Now consider complete mechanical failure of the abdominal wall with zero feedback. When I originally described the pressures on the stomach wall, I concluded that the outer gastric wall pressure generated by the abdomen dominated. However, in complete mechanical failure of the abdominal wall, no external gastric pressure is generated. Pressure generated within the stomach is now dominant. Intragastric pressure is only generated when the meal volume exceeds stomach capacity. Since the stomach empties rapidly, patients eat continuously to keep the stomach full. They complain of constant hunger despite being obese. This phenomenon of complete mechanical failure of the abdominal wall has been observed in Prader-Willi syndrome and extreme obesity cases. The stomach-generated feedback signal is much smaller and of shorter duration than a normal abdominal wall feedback signal. As a result, AF is not much greater than 1, or is dietary dependent, resulting in unregulated obesity. In summary, obesity requires decreased feedback. High-fat diet by itself cannot produce obesity. Increasing A when AF is already much greater than 1 will have no effect on weight. Decreased stiffness of the abdominal wall and increased volume capacity of the abdomen are the most common causes of mechanically produced acquired obesity. The combination of decreased feedback with high-fat diets can result in AF much greater than 1, producing regulated obesity. Throughout the world, the high-fat Western diet has increased in prevalence, and so has obesity. There are multiple methods of weight reduction. Diet and exercise are proposed first because they do not require medical or surgical intervention. Permanently changing to a lower-fat diet, decreasing A, can reduce weight, producing AF not much greater than 1. As a result, weight becomes dietary dependent and varies with A. Exercise is designed to increase abdominal stiffness and decrease abdominal volume capacity will increase feedback. Core exercises of sit-ups, planks, and plies can increase feedback if the patient is willing to perform and maintain them. Severe damage to the abdominal wall can create irreversible changes, resulting in permanent weakness, and exercise will be unsuccessful. Similarly, hernias are a complete mechanical failure of the abdominal wall and cannot be cured with exercise. Diet and exercise are the essential first steps, but may not be sufficient depending on pathology. Medical therapy with GLP-1As decreases stomach emptying and intestinal motility. The increased volume within the intestinal tract allows less room for intra-abdominal fat and weight is reduced. This does not increase abdominal strength or decrease abdominal volume capacity. GLP-1s do not reverse the cause of obesity, but result in weight loss by increasing feedback. The least invasive surgical technique to increase feedback is liposuction of the extra-abdominal fat. Abdominal wall liposuction directly decreases weight by fat removal and maintains reduction by increased feedback from decreased D, the ratio of intra-abdominal fat to total fat. Liposuction can be done safely as outpatient with minimal incisions, complications, and cost. When the abdominal wall is liposucked, the fat layer between the skin and muscle is reduced. After surgery, the compressive liposuction garment increases intra-abdominal pressure and shortens the stretched abdominal muscles, increasing strength by Starling's law. The combination of increased D, increased intra-abdominal pressure, increased abdominal strength, and decreased abdominal volume provides the physiologic advantages that treat the pathology of obesity. Bariatric surgery is restrictive or malabsorptive. Neither technique changes the pathology of obesity. Malabsorptive surgery decreases A, and the product AF may not be much greater than 1, and weight is A dependent. Restrictive bariatric surgery, such as gastric sleeve, increases intragastric pressure by decreasing stomach capacity. When increased gastric pressure inside the stomach exceeds intra-abdominal pressure on the external surface of the stomach, then intragastric pressure generates the feedback signal. The disadvantage is that when the stomach volume decreases from rapid gastric emptying, the satiety signal ends rapidly, resulting in continuous eating to limit hunger. Abdominoplasty with mesh reinforcement is plastic bariatric surgery that mechanically increases intra-abdominal pressure, decreases abdominal volume capacity, and increases abdominal wall stiffness due to the mesh and indirectly by Starling's law. This operation requires general anesthesia, lasts approximately 3 hours, and requires overnight stay. The mesh lies beneath the fat layer and directly increases intra-abdominal pressure. The increased intra-abdominal pressure can elevate the diaphragm and create pulmonary compromise. It is important to minimize intra-abdominal fat prior to surgery by diet, exercise, GLP-1s, A's, or liposuction. In cases of severe obesity, the abdominoplasty mesh may need to be repeated. Abdominoplasty mesh reinforcement directly reverses the pathology of acquired obesity. My current recommendations for weight reduction and obesity are to begin with a low-fat diet and abdominal core exercises. Patients must be educated to understand the huge variations in the fat content of food. Weight reduction requires a permanent dietary fat reduction, not a short-term diet. Exercise must be designed to increase the mechanical strength of the abdominal wall. Exercise is designed to consume calories without mechanically abdominal changes will be ineffective. These 2 steps require patient compliance and reflect their commitment to achieving success. The results may be effective for weight reduction or reversible obesity, but more severe pathology will require additional measures. GLP-1A is the next step when possible. The increased GI tract volume creates satiety with smaller meals. Over time, intra-abdominal fat volume decreases and a reduced weight is achieved. Not all patients can tolerate GLP-1s, and cost may be a factor. Also, when GLP-1As are discontinued, weight can unfortunately increase. The surgical alternative to GLP-1As is abdominal wall liposuction. Removal of extra-abdominal fat and the compressive garment increases feedback. In severe cases, abdominal liposuction can be repeated. If GLP-1A and/or abdominal wall liposuction is insufficient, then abdominoplasty with mesh reinforcement is recommended. This operation should be performed after maximum decrease of intra-abdominal volume has occurred, and GLP-1s have been discontinued for at least 2 weeks to prevent gastric reflux. In severe cases of obesity, it may be necessary to repeat the abdominoplasty with mesh after additional courses of GLP-1As. Repeat abdominoplasty with mesh reinforcement can ratchet the intra-abdominal volume down to achieve a normal weight. Weight regulation and obesity are complex but understandable. There are several key concepts. The body senses volume, not weight. Satiety is normally achieved by volume loading of the abdomen, not the stomach. Intra-abdominal fat volume is directly sensed. Total fat volume is indirectly sensed. The most difficult concept to understand is that the mathematical product of amplification time feedback determines system function. When the product AF is much greater than 1, F determines fat volume. As AF decreases to not much greater than 1, A becomes a more significant factor determining fat volume. F depends on the mechanical properties of the abdomen, some of which are fitness dependent. A depends on the fat volume concentration of the meal consumed. Obesity requires reduced F, and therapy requires elevating F towards normal. Diet, exercise, medical, and surgical therapy are capable of changing A or F and creating new set points which can cure obesity. You can find additional information in my book, Weight Regulation and Curing Obesity. If you have any questions or comments concerning these 5 lectures, please contact me at 281-565-8099 or email at plasticpromd@yahoo.com. Thank you.